Hello, my name is Vivian Haggerty, and this presentation is called Ventriculoatrial Shunts as an Alternate Therapy in Patients with Normal Pressure Hydrocephalus Refractory to Ventriculoperitoneal Shunts, a case series. Normal pressure hydrocephalus is the pathological enlargement of ventricular size with a normal opening pressure in the absence of a structural blockage of cerebrospinal fluid, or CSF. Its potential reversibility prompts the necessity for reliable treatment modalities. The first-line treatment for NPH focuses on CSF diversion to reduce the ventriculomegaly. Diversion is attained through shunt insertion from the ventricular system into other cavities of the body, such as the peritoneal cavity, the pleural cavity, or the right atrium. Most commonly, the diversion of CSF is into the peritoneum via a ventriculoperitoneal, or VP, shunt. A significant limitation with VP shunts is their rate of failure, which is especially evident in the setting of increased intra-abdominal pressure, or IAP. CSF flow is determined primarily by the pressure differential between the intracranial and abdominal cavities. The increase in IAP can cause a significant reduction in CSF flow into the peritoneal cavity, ultimately resulting in minimal to no clinical improvement of symptomatology following shunt placement. We analyzed the successful placement of ventriculoatrial, or VA, shunts in 2 patients with NPH and elevated IAP secondary to truncal obesity. We describe the clinical course of these patients and recommend a VA shunt for treatment of NPH in select patients. Case 1. 82-year-old male began suffering from short-term memory loss, urinary incontinence, and shuffling gait. Lumbar puncture led to improvement, and a VP shunt was placed with no improvement in gait or cognition. Symptoms progressed with deteriorating memory, cognitive impairment, and an unsteady, worsening shuffling gait. In clinic, a shunt tap produced improvement in gait and cognition within 24 hours. 2 weeks later, the patient presented to the emergency department with neurological decline, aphasia, and intermittent confusion. Head CT revealed evidence of worsening hydrocephalus. The catheter from the previous ventriculoperitoneal shunt was noted to be correctly positioned. Of note, the patient's BMI was 27 with truncal obesity. We felt the shunt was not performing optimally due to high intra-abdominal pressure, and the following day converted his VP shunt to a VA shunt. On post-op day 1, the patient was noted to be more alert. At a 6-month follow-up, he continued to demonstrate improved mentation and reported less urinary frequency and improvement in his walking through longer strides and being able to walk for longer periods of time. Case 2. 87-year-old male experiencing short-term memory loss, shuffling gait, and urinary incontinence was seen by a neurologist who then referred him to a neurosurgeon based on CT head findings revealing ventriculomegaly. A VP shunt was placed based on an initial diagnosis of normal pressure hydrocephalus. Following the procedure, his shuffling gait and cognition continued to worsen. A CT brain revealed mild hydrocephalus with a shunt in place. In clinic, a shunt tap drained 35 cc's of CSF. His family reported improvement in his walking and cognition over the next 24 hours, after which his symptoms returned. We felt these findings were consistent with shunt malfunction. Upon testing the distal shunt, we observed a distal pressure of 25 centimeters. Of note, his BMI was 28 with truncal obesity. We felt this pressure indicated an excessively elevated intra-abdominal pressure and converted the shunt from VP to VA. At 10-month follow-up, the patient continued to experience improvement in walking, urinary frequency, and mentation. The diversion of fluid performed by shunt therapy for NPH is dependent on a distal pressure lower than the patient's intraventricular pressure. Overweight and truncally obese patients may have elevated IAP of great clinical significance for VP shunt placement, and this variable merits consideration when neurosurgeons select which distal cavity is most important for their NPH patients. Our results examine only cases of successful VA shunt therapy for NPH in patients with IAP secondary to obesity, but IAP is seen in other pathologic conditions, such as cirrhosis, hepatorenal syndrome, nephrotic syndrome, and decompensated heart failure. Further research is needed to assess the appropriate target for distal shunt placement in non-obese patient populations, and more research is needed to confirm or refute our findings.